has been the evolution of combination therapy most recently?
So exactly, building on single agent, promising result but not super successful, several trials have lumped the non-clear cell subtypes together and evaluated a couple of combinations. And I believe you led one of the biggest one, Keynote B61, which evaluated pembrolizumab and lenvatinib in non-clear cell RCC. Patients were non-treated, so they were treatment naive, and we really had a jump in the objective response rate and PFS from the 20% to here we had approximately 49%, and median PFS around more than a year and 18 months, And here we also had some successes in individual subtypes of non-clear cell RCC, but we'll discuss that in a bit. We also have another immune checkpoint-based therapy, which is cabo-nivo, that was led at MSKCC. And here again, we're almost at 50%, so 48%, 49%, I believe, of objective response, with PFS also reaching two-digit numbers here. And we had a median OS of, I believe, 28 months.
Yeah, so we're changing the game because for the first time, we are seeing a response rate around 50%. So every other patient will achieve significant tumor shrinkage, with this PFS being above 1 year, not only 1 year, but reaching 1.5 years. So this is very different from single agent TKI we've seen for a long time. Maybe we're selecting well those patients because, as you stressed, these are phase 2, and these are non-randomized phase 2. So the contribution of the component is something we may want to challenge here, but at least we have 2 consistent trials. And as you stressed, we had enough patients, at least in the len pembrolizumab study, the B61, to look into the different subtypes.
Exactly.
So let's dig in the different subtypes. So Tian, again to you, papillary RCC is the most frequent of these entities. Within the B61, it was actually the larger body of patients, almost 100. It was also the largest in the pembro single agent study. So how do you treat papillary RCC now?
Yeah, there's a lot of good data, single cohort phase 2, but a lot of good data for combination treatment. I think, if we're very purist, we're still, as a community, I think, in kidney cancer, still thinking about, can we test the contribution of components? So when somebody with papillary kidney cancer comes in, I talk to them about the single agent data with cabozantinib. I talk to them about the combination data with lenvatinib and pembrolizumab, cabozantinib, nivolumab, smaller cohort. And then I also talk about the trial that is ongoing in the NCTN, PAPMET-2 of cabozantinib versus cabozantinib with atezolizumab. And so at that point, we make a shared conversation and decision. And I would say, because we've made such progress, it's great to see progression-free survival over a year. It's great to see responses, right? We want to aim for responses and tumor shrinkage. Our patients are more encouraged when they see something shrink. So it's great that we're having more than 50% of patients have some responses. If I remember correctly, the Len-Pembro paper also had 10% of folks had some complete responses. And so if we're shooting for a complete response, maybe they're picking that as well.